From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello, and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. The diagnosis of melanoma has been rising significantly in the past several decades. And the reasons for this increase are multifactorial and incompletely understood. Recent control studies have shown significant discordance between pathologists rendering diagnoses of melanocytic lesions. In a new study in JAMA Dermatology, authors aimed to identify pathologist characteristics associated with the tendency to diagnose melanocytic lesions as higher grade versus lower grade, or to diagnose invasive melanoma versus any less severe diagnosis. Dr. Kathleen Kerr is a professor of biostatistics at the University of Washington in Seattle. She's the first and corresponding author of this new study and is here to discuss its findings. Welcome to the podcast, Dr. Kerr.
Thank you. It's a pleasure to be here.
It is not often that we have a non-dermatologist on the podcast, but I think for this type of paper that has some more technical methods, it's great to have a biostatistician on to discuss the study. And as a biostatistician, how did you get involved in this melanoma space?
Well, I have a wide variety of collaborative experience. So I work with nephrologists. I work on a study called the Dog Aging Project, which is hosted out of the University of Washington, as well as Texas A&M and other sites. But I got involved in this work because I started working with Dr. Joanne Elmore, who was at the University of Washington previously, although she is currently at UCLA.
And this specific study that is being published in JAMA Dermatology, its inspiration was based on some previous work done by Joanne Elmore in your group. You mind telling the audience a bit about some of the other work that you've done in this space regarding melanoma diagnosis?
Yes, so Dr. Elmore's group did the MPATH study, the melanoma pathology study, and that was before I joined that group. But they used a repository of 240 cases of melanocytic lesions. Their study participants were pathologists who reviewed those cases. Each participant diagnosed their cases on two different occasions, separated by a washout period. And that study, which was published in 2017, documented high both intra-observer and inter-observer variability in the diagnosis of cases. So different pathologists diagnosing the same cases, the same case gave different diagnoses and importantly, different diagnoses. And even the same pathologist diagnosing the same case on two different occasions would often give a different diagnosis.
Yeah, and what was really interesting about that study as well is that the differences also were across the benign and malignant spectrum. So some pathologists would diagnose some things as benign, whereas others would have it diagnosed as malignant. And even within themselves, by the separation of two separate occasions, may even also render different diagnoses.
Yeah, it was really quite remarkable, although the bulk of the variability was really in the middle of the spectrum. So some cases were clearly benign or clearly malignant to everyone who interpreted them, but the cases in the middle, there was much more variability.
So then you see this work in the paper that is being published in JAMA Dermatology as an outgrowth of that. What question did you have that you wanted to answer with this new paper as a next step in that previous 2017 study?
So two realities about melanoma diagnosis have, in my opinion, been made quite clear in the literature. So one is the diagnostic variability, which we just discussed, and the other is the compelling epidemiological evidence of melanoma overdiagnosis that Dr. Gil Welsh has done and you have participated in. So that was the background going into this study. And we wanted to see if we could identify characteristics of pathologists associated with tendencies to give certain diagnoses as a way to help perhaps understand the sources of diagnostic variability and perhaps provide some insight into the phenomenon of overdiagnosis.
And so this was an analysis based on the two prior studies that you were involved in, Empath and REMI, correct?
Correct. So both the empath study and the subsequent REMI study had practicing pathologists who interpret melanocytic lesions in their practices, interpret cases from a repository of 240 melanocytic skin lesions, and all the case interpretations were independent. And altogether, there were 338 pathologists who participated in one study or the other. And they provided over 11,000 diagnoses of those 240 cases. And every pathologist did not interpret all 240 cases, but in each study, they were randomly assigned a set of cases to interpret. So we thought that we could look at some pathologist factors and look at cases where a variety of diagnoses were given and see if we could identify factors associated with, say, a tendency to diagnose higher grade versus lower grade, or a tendency to diagnose invasive melanoma versus a less severe diagnosis.
Before completing the analysis of this study, were there specific characteristics that you thought perhaps might be associated with rendering a more severe diagnosis or not? And what kind of characteristics did you collect as part of this study that you could actually investigate some of these associations?
So we were limited to studying characteristics that had been collected in these prior studies, the empath and REMI study. I'll also mention this was an exploratory analysis. We didn't come in with a strong hypothesis about what we expected to be associated. So some of the characteristics that we looked at were pathologist age, which we can think of as being maybe a proxy for when they went to medical school or when they got their training, geographical region, whether the physician was affiliated with an academic medical center, whether they were board certified in dermatology, and so forth. And one of the factors we looked at was whether a pathologist was a dermatopathologist, either board certified or fellowship trained in dermatopathology or both, versus what we call a general pathologist, so a pathologist without that specialist training.
All right. So you have these characteristics, you have all of the diagnoses that are rendered from both of these studies, the REMI study as well as empath. What did you find?
The factor that jumped out was specialty training in dermatopathology. Dermatopathologists had about 2.6 times higher odds of diagnosing a case as higher grade compared to general pathologists interpreting the identical case. And dermatopathologists had about twice the odds of diagnosing a case as invasive melanoma compared to general pathologists interpreting the same case. Given that being a dermatopathologist or general pathologist was the predominant factor, we decided then to further analyze those two groups of physicians separately. So within those groups, we found some other potentially interesting associations. So for example, within dermatopathologists, a higher practice caseload of melanocytic lesions was associated with rendering more higher grade diagnoses. And among general pathologists, those affiliated with an academic medical center were actually less likely to diagnose invasive melanoma in our data.
That's pretty interesting. Well, I mean, all of that data to me is pretty fascinating, but I'm biased because this is one of the areas of research that I do is melanoma. But I was struck at that 2.6 odds increase for dermatopathologists. Did your authorship team, which also included dermatopathologists, have a hypothesis as to why this is the case?
Yeah, we can only speculate. We don't really have any ability from the data to learn. There's a sense that maybe dermatopathologists more than general pathologists have been exposed to the efforts about the importance of early detection that may lead them to be more sensitive. And, understandably, everyone is worried about missing a true case of melanoma. And perhaps for some reason, dermatopathologists are more attuned to that. I'd be interested to hear your thoughts about that finding as well.
I think that's perhaps part of the reason that dermatopathologists are more sensitive to subtle changes on the slide that perhaps a general pathologist is not, and therefore may have a lower threshold to call things melanoma. Now, what I would also say is that it's impossible to know who's right here, right, or who's correct,
That's true.
because there are no clinical data that were associated with these diagnoses on the slide. Meaning, by clinical data, I mean outcome data, meaning who progressed, who didn't, who might have a recurrence or metastasis. That information was not part of this study. And it's possible that the general pathologist maybe missed a lot of melanomas. That's also possible.
That's a really important point. And I think we're very clear in the paper that we cannot definitively say when we see variability. Are some pathologists overcalling? Are some pathologists undercalling? But at the same time, we also do interpret our results in the context of knowing the epidemiological data pointing towards overdiagnosis, leading us to be inclined to think that when there's a lot of variability, that some of those higher diagnoses may represent overdiagnoses.
Hmm. And there's been this idea that perhaps we should change the name for some of these malignant tumors that have a low potential of being bad actors, i.e., progressing and metastasizing. I don't know if you have any thoughts or ideas about that. I don't want to push you too hard here because I know you're not a clinician, but
Yeah, I'm not a clinician, but as a non-physician, I do have some experience on the other side of receiving, it's a very difficult thing to receive a serious diagnosis. And yeah, so some of my dermatopathology colleagues are proponents of considering alternative terms for some diagnoses. So one term is melanocytic neoplasm of low malignant potential, which might communicate to patients that they have a lesion. It isn't normal. It has some potential to become malignant, but perhaps we shouldn't be labeling it a cancer or malignancy yet, because it still, I think, is quite true in the general population that people assume cancer is cancer and all cancer is deadly, when the reality is much more complicated.
yeah. And I've heard those kind of calls, and some people they push back and say, well, you could call it something different, but if clinicians still remove the lesion via surgical excision, have you really changed the downstream effects by simply changing the name? And perhaps by changing the name, would also hamper our ability to really study how much overdiagnosis is happening in the United States or abroad, and also maybe it will just confuse patients more. Now, I don't know which one of these reasons are, things that we should be concerned about or what's more true versus not, but I think that the issue of changing the name or changing how you behave is really, really something that's complicated.
Yeah, there are a lot of things to consider, and I'm not sure it necessarily has to change practice to consider changing a name, changing terminology. I mean, one thing about melanoma is the biopsy itself, as I understand it, is already a kind of treatment. You often remove the whole lesion, and that doesn't necessarily have to change.
Yeah. And it also could, by changing the name, perhaps, as you pointed out, you could limit some of the psychological consequences of being labeled as somebody that has a cancer versus somebody that does not. And possibly this could create a scenario where these lesions could be better studied, say, perhaps at the molecular level, to see if there are some signatures that may help differentiate between those that truly have low malignant potential versus those that do not.
Yes. Yeah.
Yeah, your study raises a lot of really interesting and important things to think about. Is there anything else about the study that you found fascinating that potentially may have some implications for clinical care?
Yes, so going back to our finding that dermatopathologists had about twice the odds of diagnosing a case as invasive melanoma compared to a general pathologist interpreting the same case. My colleague and co-author Ray Barnhill prodded me to dig a bit deeper into different types of diagnoses of invasive melanoma. So based on his insights, we separated out diagnoses of invasive melanoma of T1A with zero mitotic counts. And these are believed to be very low risk diagnoses. So we did this one post hoc analysis where we pulled those diagnoses out of the diagnoses of invasive melanoma and grouped them into the less severe category. And once we did that, the association that we saw between specialty training and diagnosing invasive melanoma actually completely went away. It was remarkable, actually, how clean the difference was. So it really told us that if you think about there being extra diagnoses of invasive melanoma among the dermatopathologists, that those extra diagnoses were all concentrated into T1A with zero mitotic counts. And as I understand it, these are diagnoses where it really is much more of a judgment call whether the diagnosis is actually invasive melanoma. But you could speak to that more than I could.
Well, certainly there is some gray there, and it does make sense to me that this is the area where specialist training may influence just how sensitive you are at picking up some of these subtle abnormalities. And there has been a paper from Joanne Elmore's group looking at these really early types of melanoma that are not mitotically active and looked at clinical outcomes over time in a population-based fashion and find that these tumors do indeed have very little to no effect in terms of melanoma-associated poor outcomes. So it is possible that further study of this group of tumors to figure out whether we can treat them a bit differently or treat the patients a bit differently or counsel them a bit differently than those that receive more severe and clear diagnoses of melanoma.
Yes, so I think you're referring to the paper on the SEER data with
Yeah.
Gucci et al. Yeah, in that paper we used SEER data, so that wasn't an analysis of our study data, but it was analysis of SEER data. And we identified subsets of patients and the characteristics of their diagnoses and identified subsets of people who have perhaps a very low risk of 7-year melanoma mortality, like perhaps a 1 in 200 risk of melanoma mortality, which again tells us maybe there's some potential for malignancy there, but perhaps patients shouldn't be as terrified at their diagnosis that they otherwise might be.
Well, Dr. Kerr, it was fantastic talking to you about this really broad and interesting topic. And I want to thank you for taking the time to speak to me on the podcast. You can find a link to the paper in this episode's description. This episode was produced by Daniel Masisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.